with NVPHE, and Dr. Lander will be starting the epidemiology review session in a moment. I wanted to let you know that I posted a link to where you can access the slides for this presentation in the chat box. So if you haven't checked that, please do. I will try to answer any other questions regarding where these will be located and where the recorded session will be posted kind of as we go through. This will be recorded, and our time frame is approximately 3 to 5 working days for us to be able to prep it and post it. It will be posted at the same location where you'll pull the files for the slides for today from. I think that's it. Dr. Lander is going to start the presentation. We'll have a couple of breaks, and at that point in time, she will answer your questions. Thank you guys again for joining. Dr. Lander?
Hi, good morning, everyone. I'm happy to review epidemiology's questions with you. My name is Lena Lander. I'm Associate Professor at the Department of Epidemiology, College of Public Health at the University of Nebraska Medical Center, and we're in Omaha, Nebraska, so right in the middle of the country. So today I will review basic topics covered in the epidemiology section of the exam. Just a disclaimer, the materials we're reviewing today cannot replace a basic epidemiology course. I strongly encourage you to review your textbook. And as Heather said, this presentation will be archived. This is the outline for today. We'll go through overview, some terminology, discuss study design, principles and methods, then talk about causation and validity, and finish off with screening. So let's start with populations. Population is a group of people with a common characteristics. They can have, the common characteristic can be a place of residence, age, gender, religion, so it could be all residents of New York City, for example. Here I have people who live in Omaha, Nebraska in January of 2014. Population can also be some occurrence of a life event, so maybe people are undergoing cancer treatment or giving birth. And why do we care about populations? Because those are considered in all the calculations we're doing, and just a review, epidemiology is a study of distribution of diseases in population. So we're really operating on this population scale. The membership in a population can be permanent or transient. So population with permanent membership, sometimes referred to as fixed or closed. And for example, people who were present at Hiroshima, or passengers on an airplane. All of you, once you pass the CPH exam, will be CPH certified. That's another population with a membership. Population can also have dynamic or open membership. For example, a current population of Omaha, where people can move into the population and also leave the population. So any city population, people can migrate in or migrate out. That would be open or dynamic population. Let's talk about measures of morbidity or measures of disease. The first basic measure of frequency is the count. It's the initial measure we look at when we are encountering disease that we're not sure what is going on with it. So count is just a basic unit of frequency. Oftentimes it's expressed as integers, so whole numbers of people with the disease. When the SARS outbreak started in China and then Canada, the public health officials didn't know how to deal with this new disease, so they started counting number of people with the disease. The count is often a numerator in many measures that we'll go through next, and it's important to distinguish between incident or new cases and prevalent or existing cases. Here's a figure on the counts of cancer deaths. So we have thousands of deaths on the y-axis and years on the x-axis. And you can see that the number of deaths increased over time. The ratio is another basic measure, and it's one number that's divided by another. So if we have x over y. X is the numerator, y is the denominator. So it's a basic ratio, one divided by another. The ratios can range from 0 to infinity, and the two components of the ratio can be related to each other, as in number of female children divided by all children who visit the clinic, or they can be independent, number of female children divided by number of male children. So here's the first question from the CPH exam. Which of the following terms is expressed as a ratio as distinguished from a proportion? A, male births divided by male plus female births. B, female births divided by male plus female births. C, male births divided by female births. D, stillbirths divided by male plus female births. And the correct answer is C. The ratio is just one number divided by another. So it's male births divided by female births. Okay, let's keep going. Proportion is a ratio in which the numerator x is included in the denominator. So it's usually x divided by x plus y. And it can range from 0 to 1. So the most it can be that the entire numerator is included in the denominator. It's often expressed as percentage. For example, among all children who attended the clinic, what proportion was female? So it would be female divided by all children. It's a proportion. So we ask, what proportion of children who attended the clinic was female? The rate, on the other hand, has a time component. So every time you see a rate, think, oh, it has to have a time component. So it can be expressed as A over T, where A is the number of cases and T is some component of time. It can range from 0 to infinity, and it measures the speed at which things happen, the speed at which at-risk females are coming to a physician clinic, the rate of disease transmission, for example. Well, let's start with basic measures of epidemiology. Prevalence is the first one. Prevalence is a proportion. It is not a rate. There's no time component in the calculation itself. It measures the proportion of existing disease in the population at a given time. So you can think of it as a snapshot. If we took a snapshot of a population, what proportion of the existing disease cases do we see in the population? It is a dimensionless and positive number. So prevalence can be calculated as number of existing cases, denoted by A here, divided by total population. And total population, or N, includes both the existing cases and non-cases, meaning healthy individuals as well. Incidence, on the other hand, measures the occurrence of new cases in a population at risk over time. It can be measured as a proportion or a rate. And its most fundamental epidemiologic indicator, it measures the force of morbidity as a rate, how quickly or what is the rate at which disease is transmitted in the population. And it can be thought of as it measures conversion of health status from healthy to disease. So it's a proportion or a rate. Some synonyms for incidence proportion are just incidence, cumulative incidence, or risk. Incidence proportion measures the probability or risk of developing disease during a period of observation. And that period can be a month, it can be a year, it can be a decade. It's a dimensionless positive number. So incidence proportion, it's the number of new cases of disease, new onset cases, divided by population at risk at the beginning of your study time, or the time you were interested in looking at. The key with incidence is that we're dealing with new cases of the disease. These are newly infected individuals or newly diagnosed cases. Whatever the disease you're looking at, incidence is always the new cases of the disease. And the way I remembered it, the second letter is the incidence is N, so that was a reminder for me that I have to think of the new cases of the disease. So incidence proportion is appropriate for fixed or closed populations and short follow-up times because we're dealing with the time component. So we need to be mindful of what time interval we're looking at. We must specify time period of observation because risk changes with time. Incidence proportion is not appropriate for long-term follow-up due to potential loss of participants, and it assumes complete follow-up or the same risk over time. Here's another example. We want to follow 2,000 newborns at monthly intervals to measure the development of respiratory infection in the first year. And we suppose that 50 infants develop respiratory infections in the first year of life. So the incidence proportion is the number of new cases of the disease, or 50, divided by the number at risk, the population at risk, and those were 2,000. So 50 divided by 2,000 is 0.025, and it's often expressed as percentage, so we can do the same here, or 2.5%. How do we interpret incidence proportion? It is the risk or probability of developing a respiratory infection in the first year of life, and that's 2.5%. We can also express this number as proportion, so 25 out of 1,000 infants in this population, or 1 in 40, will develop infection in the first year of life. So you can see from this example why this time interval is very important. If we're dealing with the first year, the incidence proportion would be very different than if we were asking about the first months, for example, of the study. So it's important to specify what time interval we're looking at. The incidence rate, on the other hand, measures how rapidly new cases develop during a specified time period. It is calculated as cases per person time, and again, we're dealing with new cases. Some synonyms are incidence, incidence density, or just rate. It is useful because follow-up may be incomplete. So in the previous example, it may be very difficult for investigators to follow up the entire sample of 2,000 participants, and if some of them, let's say, left the state or became not interested or wanted to stop participating, they could not be counted in the incidence proportion. But we can still calculate the incidence rate because it does not require complete follow-up, and the risk period is not the same for all subjects, so it takes that into account as well. So incidence rate is calculated as the number of new onset cases, or A, divided by person time at risk during study period, or follow-up time. What is this person time at risk? It's a term that sometimes is confusing. Well, it accounts for all time each person is in the population at risk. It's the length of time for each individual is called person time, and then we sum up individual time contributions for a total of person time at risk for the entire population. Basically, we're looking at the sum of all individual contributions of time at risk for all study participants. So here's an example. Suppose we were doing a study with 5 people over 5 years, and this is, of course, oversimplified. And each of the horizontal bars represents one person. So person 1 enrolled at time 0 and then died right at the end of year 1. Person 2 completed the entire 5 years of follow-up without the disease. Same thing for person 3, completed the entire 5 years of follow-up. Person 4 completed 3 years, and person 2 completed 2 years. And they got the disease, let's say. So the person time is the sum of the individual contributions of the time components for the entire population, and in our case it's 5 people. So if we added up individual time contributions, we end up with 16 person years, and that becomes our denominator for the calculation of incidence rate. Now, the person time assumption states that it doesn't matter whether we're dealing with more people or more years. Those person years are equivalent. So if we followed 100 persons for 10 years, we end up with 1,000 person years. Or if we followed 1,000 people for 1 year, we still have 1,000 person years. And in these assumptions, those two units are equivalent. So of course you have to be mindful of which disease you're investigating, because that may not be the case, and so that's important to consider too. So person time assumption states that whether it's more people followed for shorter time intervals or fewer people followed for longer time intervals, those person years are equivalent. Let's look at another example. If we followed 2,000 newborns at monthly intervals to measure the development of respiratory infections in the first year. So again, we have 50 infants who develop respiratory infections. 1,900 complete the entire year disease-free. Those 50 who develop the infection, 25 of them get the disease at month 3. So it's quarter of a year before the infection, and then 25 complete 6 months disease-free. So that's half a year. To calculate incidence rate, the numerator is 50, the number of people, the number of new cases of the disease, and the denominator is the sum of individual time contributions. So 1,900 contributed the entire year. They were at risk for the disease. The 25 next contributed quarter of a year before they got the disease and stopped contributing time at risk. And then additional 25 contributed half a year. So the denominator is 1,900 plus 25 times 0.25 plus 25 times 0.5. And that results in 2.6 per 100 person years. Just to note, this 100 can be interchangeable. So if we wanted to express for 1,000 person years, for example, we would just divide this number by 10. Here is a good schematic from the Leon Gorda's book on the relationship between incidence and prevalence. So we can think of prevalence as the number of disease cases in the population. How can prevalence increase? Well, if more people get sick, the prevalence will increase. So prevalence increases as new cases are added to the existing cases. The new cases is what is indicated by incidence. So the higher the incidence, the higher prevalence will be. And you can think of this marbles dropping into some vessel. Prevalence can also decrease as people die from the disease or they're cured from the disease. So prevalence decreases as people are cured or die. And the formula is prevalence equals incidence times duration. So let me pause here and I'll take some questions. Somebody asked if incidence is the same as the incidence proportion. The term incidence by itself is used sometimes interchangeably with incidence proportion. So incidence proportion, let me go back. is the number of new cases of the disease divided by population at risk. So it's a proportion. Incidence rate, on the other hand, is the number of new cases divided by population, person time at risk. Okay, let's keep going. And then I'll also leave some time for questions at the end. So measures of mortality is next, and mortality is death, basically. It's mortality measures the occurrence of death. It can be also either a proportion or a rate, and it measures disease severity or effectiveness of treatment. And that makes sense theoretically. So the more severe the disease, the higher is the expected mortality rate, or the more effective is the treatment. So as more people are cured from the disease, we expect mortality to decline. So mortality rate measures, it's a rate of death in the population over a specified amount of time. It's a positive number again, ranges from 0 to infinity. And it can be thought of as a measure of incidence rate when the disease is severe or fatal, for example, pancreatic cancer. Sometimes it's referred to as fatality rate. And here's how we calculate the mortality rate. The numerator is number of deaths, or D, divided by total population at midpoint of your time period. And the time period is the follow-up time, usually 1 year, depending on the study you're reading or the questions for the exam. So mortality rate is the number of deaths divided by total population at midpoint. Here's an example of cancer death rate. The y-axis shows the rate per 100,000 population, and the year of death is on the x-axis. So you can see how calculating these rates allows us to do two things. We can look at the trends over time. So we see that the lung and bronchus cancer, denoted by the blue line, really increased over time up until about 1990, and then declined, and then started to decline. We can also compare different cancer rates. So for example, stomach cancer showed by this lighter blue line steadily declined over time, whereas colon and rectum cancer shown by the orange line stayed pretty stable and then declined as well. So case fatality rate is another measure of mortality, and unfortunately it is not a rate, it's a proportion. That's a misnomer. It's a proportion of deaths from a specific illness. So case fatality rate is number of deaths from that disease divided by number of people who have that disease. So it can answer a question, what percentage of people diagnosed as having a disease die within a certain time after diagnosis? What percentage of people diagnosed with stomach cancer die from stomach cancer within 1 year interval of diagnosis? So case fatality rate is a useful measure of the severity of the disease. The more severe the disease, the higher case fatality rate is expected. It can be used to measure the benefits of new therapy. So if therapy improves, we expect mortality to decline, and case fatality rate can reflect that. Proportionate mortality is a little different, and it looks at of all deaths, what proportion is caused by certain disease. So for example, the proportional mortality from cardiovascular disease in the US in 2013 would be number of US deaths from cardiovascular diseases in 2013 divided by total deaths in the US in 2013. So you'll notice that it's important that The location is the same, so both were looking at the United States, and the year is the same. Both the numerator and denominator are referring to 2013. So proportionate mortality looks at the proportion of deaths from a specific disease divided by total deaths in that same population in the same time interval. So it can help us determine the leading causes of death. That's how public health officials come up with recommendations, perhaps allocate certain screening or intervention programs. This measure does not tell us the risk of dying from a disease. So here's another question from the website. Which measure of mortality would you calculate to determine the proportion of all deaths that is caused by heart disease? Case fatality, cause-specific mortality rate, crude mortality rate, proportionate mortality ratio, or potential years of life lost? And the answer is D, proportionate mortality ratio. It shows us the proportion of deaths caused by specific disease divided by total deaths in that population. Some other mortality rates that are commonly used. The crude mortality rate includes all deaths divided by total population in a specific time period. The cause-specific mortality rate includes all deaths from a specific cause divided by total population in a time period. So, for example, all deaths from pancreatic cancer divided by total population in the United States in 2013. The age-specific mortality rate includes all deaths in a specific age group divided by population of that specific age group in a certain time period. So if I wanted to know age-specific mortality rate in a 10 to 15-year-old age group. So we would look at all deaths among the 10 to 15-year-olds divided by number of people in that age group. How many people were in the population between 10 and 15 years of age in a certain year. Here is an example of U.S. population and state age-specific mortality rates. So the first column shows the age group, next the total population for age group, and then we have two states and their age-specific mortality rates. So these types of rates allow us to compare different age groups and also compare different geographic regions. Here we're looking at a state comparison. So suppose we looked at mortality rates of two countries, Panama and Sweden. Panama has just under 3 million residents, 13,483 deaths. So the mortality rate would be number of deaths divided by population, or 4.65 per 1,000. And Sweden is 93,000 deaths divided by population, 8,923,569, or 10.47 per 1,000. So if we were just comparing the two rates, well, would we conclude that Sweden has almost 2 times higher mortality rate? Well, it's a trick question, and that's why mortality rates can be a little misleading. Yes, overall it appears that way, but not necessarily. So the difference may be due to differences in age structure of the two countries. So if we look on the left, it's a population pyramid of Panama. So we see that there are a lot more people in the younger age group. So each line in the population pyramid represents number of people in the population. We have males on the left side and females on the right side. So we can see that the population is very heavy towards the bottom, so there are a lot more younger people in the population. Sweden, on the other hand, is more square. The pyramid is more square in the shape, so there are some younger people the number of people in the middle age group is about the same, and then we have a lot fewer older people. So crude mortality rates do not take into account these differences between populations such as age. So of course, the crude mortality rate for Sweden is higher because Sweden has a lot more older people, and we know that the mortality rate increases with age. So this is where the standardization comes in. We need a way to account for differences in age distribution of the two countries or two states, whatever comparison we're making. So we can compare one way, we can stratify the population into age group and then calculate rates for each age, and then compare age-specific mortality rates. So if we went back, we could compare age-specific mortality rate, and that way it would give us a better estimate on the mortality difference in the two countries. And if two populations are different, we can adjust or standardize the mortality rate of the two populations, taking into account the age structures. So what standardization does, it takes into account those differences in age structure so that the results are actually comparable between populations. And then we can make some meaningful conclusions on the differences in mortality rates. The two types of standardization are direct and indirect. So both answer the questions: if the age composition of the population were the same, would there still be any differences in mortality rate? So direct age adjustment or direct standardization is used to remove the effects of age structure on mortality rates in two different populations. And we do this by applying age-specific rates to a standard population. And the standard population is the US population of 2000. Indirect standardization is used when age-specific rates are not available, and we use age-specific mortality rates from general population and calculate expected number of deaths. So you'll hear sometimes standardized mortality ratios, and it's number of observed deaths divided by number of expected deaths. So that helps us compare two different populations. Both direct and indirect standardization help us answer the questions if the age composition of the population were the same, would there still be any differences in mortality rates? So if we remove these differences in age composition of the two populations, the mortality rate still, our mortality rate still different, and how are they different? Where is the difference lies? Is it in the younger age groups? Is it in the older age groups? So that would allow us to make meaningful comparison. So I'll take a few questions now as well. Somebody asked, is case fatality rate always looked at 1 year, or can the time period be variable? It can be variable. It would depend on the question, and I'm sure it would clearly state what time interval you were looking at. Because the number that you calculate would be very different. Are we looking at case fatality of 1 year or 2 years or 1 month? So similarly to prevalence, the time component has to be clearly stated so you can answer the question. Somebody asked, could you explain the difference between proportionate mortality ratio and cost-specific mortality ratio? So let's go back to that example, that slide. So proportionate mortality ratio is all deaths from a specific disease divided by total deaths in that population in that time interval. So all deaths from a specific disease divided by total deaths. And you can use the name of the calculation to remember proportionate mortality. What proportion of deaths from that disease were compared to all deaths in the population. The cause-specific mortality rate is number of deaths from a specific cause divided by total population. So the difference is in the denominator. The proportionate mortality has all deaths, and the cause-specific mortality rate, the denominator, is total population. Okay. Let's keep going and talk about study design next. The studies are divided into, let me just close. Okay. The study design is one of the biggest components of epidemiology, and they can be divided into experimental studies and observational studies. Experimental studies are sometimes referred to as clinical trial, randomized controlled trial, so we'll start with those. The experimental studies there are characterized by population under study. Who is eligible to be included? The key features of the experimental studies is that investigator is making some sort of difference, whether they're administering a therapeutic drug or providing some sort of education. The interventions are used and compared. So one of the other characteristics is what treatments are being used. The method of treatment assignment is also important. How are subjects assigned to interventions? Was it random or not random? Did we take existing did we take participants from another study and assign them to a treatment? The outcomes of interest are also important, and we need to know a priori or before we start our study, how will success be measured? The randomized controlled trial is a type of experimental research design for comparing different treatments in which the assignment of treatment to patients is made by a random mechanism. So we randomly assign people to receive an intervention or another treatment. And it's customary to present a table of patient characteristics to show that randomization resulted in a balanced distribution of variables in all patient characteristics. So if we randomly assigned participants to intervention and control groups, we need to show that that randomization worked and they're in fact, the two groups are in fact similar. Here is a schematic of the randomized controlled trial. We start with our study population, and usually there are inclusion-exclusion criteria before that. So we screen participants, make sure there are no counter indications for the treatment for them to participate in our study. They're then randomly assigned to a current treatment or new treatment that we want to investigate. And then we look at proportions of participants who improve or do not improve in each group. So it's important to it is important to consider all steps before we start our study. But the key with experimental studies is that the investigator actually makes a difference. So in this case, the investigator randomly assigned participants to current treatment or new treatment. And the arrow on the right shows that we're going forward in time. We selected our study population first, assigned them to treatment, and then look for outcome. Here are the steps in carrying out clinical trial. Start with the selection of sample from the population. The sample must be representative of the population so we can make generalizations, and we'll talk about it later in the lecture. Ethical considerations must be present throughout, not just in this study, but all studies. It would be unethical to offer placebo when an existing treatment shows improvement in the study outcome or can actually make a difference. So all experimental studies now show either the new treatment that's thought to be more beneficial than existing treatment, so the second arm of the experimental study would be the current acceptable treatment. We then measure baseline variables, and that's all demographics, so all patient variables, so that we can track the progress or show the improvement. We then randomize participants into the two study arms, so new treatment versus the current treatment, apply interventions, whether it's drug, medication, or educational programs, the whole variety of studies, follow up the two groups, and then measure outcome variables. So whether we were looking for some clinical marker of disease or something else, but we need to know ahead of time what variables we'll be measuring and how we will determine what success was for that disease and that age group. Oftentimes you hear blinding, and that's basically we mask either the treatment, we mask what the treatment was if it can influence the interpretation of results. It is important when outcomes are subjective. So for example, if clinician was judging pain or functional status of a patient, and the patients were in two different groups. So if the physician, if the knowledge of whether that patient was in the experimental or control group could influence the physician's assessment of pain or functional status, it's important to blind them or to not tell them that information so that they can make unbiased assessment. So we use blinding to achieve that aim. Sometimes placebo is still used, and it can be done to ensure that control and treatment have the same experience. So it would be either the same medication without active ingredient, so people are still taking some medicine and they don't know that they're in the control group. And sometimes it may not be necessary, so blinding may not be necessary if it's an objective measure, so death or blood glucose level. It doesn't matter whether the physician or the participant know if they're in the experimental or control group if we're getting their blood and measuring blood glucose, for example. So when measure is objective, blinding may not be necessary. But when we're dealing with subjective measures such as pain or functional status, blinding becomes very important. We want to blind participants to the treatment to ensure that bias is avoided, so that patients are not reporting symptoms or outcomes differently based on which group they're assigned to. So single blind experiments, the patient do not know what treatment they're receiving. And double blind is the patient and investigator are both blinded. They don't know what the treatment was. There is also a third option that's triple blinded, where both the patient, the investigator, and the data analyst or statistician do not know what the treatment plan was. So the both the data collection, the data interpretation, and analysis could be unbiased. And the evaluation can be as clear as possible. So it all comes down in experimental studies. We want to obtain groups that are comparable in everything except for treatment. And if we do that, the difference, any difference in outcome that we find can be fairly attributed to the difference in, the only difference between the groups, which is the treatment. So if we did everything correctly and the groups were comparable when we started the study, we can be reasonably confident that any differences in outcomes that we find can be attributed to treatment, because treatment was the only difference between the two groups. So let's see if there are any questions on the experimental study. It doesn't look like it, so very good. Let's keep going and talk about cohort studies next. The cohort studies are very useful as well when we cannot do experimental studies. So the groups are defined on the basis of some characteristics of an exposure and non-exposure, and typically prospectively follow to see whether an outcome of interest occurs. The comparison of interest is we compare proportion of persons with the disease in the exposed group to the proportion of persons with the disease in the unexposed group. And if exposure is associated with disease, we expect that a proportion of people with the disease in the exposed group will be greater than the proportion of people with the disease in non-exposed group. So this is the common schematic of cohort studies. We start with exposure information. So that's the key. Cohort studies think exposure is first. And the name itself comes from the military term where a cohort, you can think of a group of people moving forward in time together. So our group of people is exposed and non-exposed. There could be maybe an occupational exposure to benzene. So some people were exposed to benzene, some people were not exposed. We then look for the outcome. We look for disease occurrence. So among those who are exposed, some will develop the disease, some will not develop the disease. Among those who aren't exposed, some will develop the disease, some will not develop the disease. And basically we're looking at the proportion of disease occurrence among the exposed and unexposed. Cohort studies can be prospective and retrospective. In prospective, we start with exposure information now, and then we follow people forward in time to look for disease occurrence. So we collect the disease information sometime in the future. Retrospective, we think of this cohort has already occurred in the past. So even though we start now, we can think of it as the cohort has already occurred. So we look for exposure information sometime in the past. So for example, if we looked at company records and found out who was exposed and who was not exposed to benzene, and then look for maybe cancer information in those same medical records. So theoretically, exposure, even though all the information was collected in the past, exposure information was still obtained first. So that's a retrospective cohort study. So with prospective cohort study, we define a sample free of the disease outcome or outcome of interest, measure the exposure, and classify who's exposed and unexposed at time 0, and then follow at fixed time points to ascertain outcome. So maybe we'll do a cohort study and then measure outcome 10 years from now, 20 years from now. We measure the ratio of outcome between exposed and unexposed group. So look at occurrence of disease among the exposed and unexposed and calculate relative risk, which we'll go through in a little while. The retrospective cohort studies are historical, so sometimes they're referred to as historical cohort, historical prospective, non-concurrent prospective study, but retrospective cohort is the main term. The study, we do not design retrospective cohort studies a priori. The question is always in retrospect. So the data are already collected, the exposure and outcomes have already occurred, and we must rely on the relevant exposures and outcomes that were collected. So we can't go back in time and tell the plant management that, by the way, 20 years from now we'll need data on benzene exposure and pancreatic cancer death. So with retrospective studies, we must rely on existing data. But the flow of information is still the same. The exposure information is collected first or obtained first. We then look for a disease occurrence and compare proportion of people who got the disease among the exposed to those who got the disease among unexposed. The cohort study strengths are numerous. They may be used to define incidence or natural history. The key for cohort studies is we know temporal sequence, meaning we know for a fact that exposure occurred before outcome, and other studies are unable to do that. They're efficient in investigating rare exposures. It is more efficient to collect find a group of people with these rare exposures and assemble a cohort with them. So for example, if we surveyed general population and we were interested in occupational exposure to benzene, only a few people would be exposed. So out of maybe 2,200,000 people may have been exposed. So it would not be efficient to do cohort studies on everyone when we're just interested in a narrow exposure. So these studies are efficient in investigating rare exposures. We can easily find a group of people who had that exposure and then a comparison group of unexposed. Cohort studies permit us to evaluate multiple exposures and outcomes. So suppose we were interested in occupational exposure to benzene, but we can also look for information on occupational exposure to toluene or another industrial solvents. We can look for multiple outcomes in a cohort study. So just we're not limited to one outcome. If we go back to diagram, we'll look for disease occurrence. Nothing is stopping us from also looking for another disease that occurred. So we can have disease 1 or disease 2, so we can have multiple outcomes. So cohort studies are efficient for rare exposure. We can evaluate multiple outcomes, and there are fewer biases in a cohort study. So we usually have homogeneous sample population, the accurate measurement of important variables, especially in the prospective cohort studies, and there's no bias in ascertainment of outcome. Some limitations, they tend to be expensive, especially the prospective cohort. So you can imagine it is very costly to keep up with a group of people to make sure we know what exposures they're experiencing, what outcomes, and how those outcomes are measured. For rare diseases, they're very inefficient. We need very large sample size and long-term follow-up. Some associations may be due to confounding, but we can adjust statistically for any measured potential confounders. We must exclude subjects with outcome present at onset. And disease with long preclinical phase may not be detected. So if it takes a very, very long time for the disease to develop, and our cohort study time was shorter than that preclinical phase, we may not be able to detect disease occurrence. So if we were doing a study of exposure to benzene and we were looking for cancer, but our study lasted only 5 years, we may not be able to detect any cancer cases. The cohort studies are also sensitive to follow-up bias, so if a lot of people are lost or die from the disease, cohort studies are sensitive to those losses. Let's see if there are any questions on cohort studies. Okay, doesn't look like it, so that's great. Let's keep going and talk about case control studies next. The case control studies, the easy way to remember what it is about is to think of the name, case and control. So case are people with disease, controls are people without the disease. So case control studies compare various characteristics of past exposure for cases, those with the disease, to those without the disease or controls. So we compare the proportion with the exposure in the cases to the proportion with the exposure in control groups. And if exposure is associated with disease, we expect the proportion of people with the exposure among cases will be greater than proportion of people with the exposure among controls. Basically, we start with disease information. So just as the name suggests, case control studies, we start with our cases and the controls. So we have people with the disease or cases, people without the disease or controls, and we look for exposure information. So among those who have the disease, what proportion were exposed in the past and what proportion were not exposed? Same thing for controls. What proportion were exposed and what proportion were not exposed? If the exposure is associated with the disease, we expect the proportion of those exposed among cases to be much greater than those who were exposed among controls. So case control studies are efficient for rare diseases. It is efficient to find a few cases of maybe a rare pediatric cancer and then come up with control groups and look for the exposure than to do a large-scale study with only a few cases. So case control studies are efficient for rare diseases. They're also efficient for diseases with long latency because the disease has already occurred. So we can just include the people with the disease. We can evaluate multiple exposures. So we already assess, we're already looking at proportion who are exposed among cases and controls. Nothing is stopping us from looking at several exposures at the same time. So we have, they're efficient for rare diseases. We can evaluate multiple exposures. And the cost of case control studies is lower compared to cohort studies. So if your budget was limited, case control study may be a better option. The incident cases are preferable for causal approach, but you can use prevalent cases as well. There can be some challenges with control selection. Sometimes we struggle with finding appropriate control group. And then challenges with retrospective exposure assessment. Case control studies by definition are retrospective. Even if we're selecting newly diagnosed cases, we're still asking about exposures that occurred in the past. It's different from experimental study where we assign treatment first and then look for outcome. With case control studies, the outcome, the disease has already occurred. So case control studies are among the best observational designs to study diseases of A, high prevalence, high validity, low case fatality, or low prevalence. And the correct answer is D, low prevalence. And another way of saying rare diseases. So low prevalence means the disease is rare, and the case control study is a good option. Okay, here's another example. We want to know whether smoking is associated with coronary heart disease. So we recruited 3,000 smokers and 5,000 non-smokers were followed to see if they developed coronary heart disease. So the table shows exposure, people with the disease, people without the disease, and total population. Is this a case control or a cohort study? And the correct answer is a cohort study. The easy way to remember is we started with our exposure. Well, we recruited 3,000 smokers and 5,000 non-smokers, and then looked for disease occurrence, then looked for coronary heart disease. So this is an example of a cohort study. We start with exposure and then look for an outcome. Next on the list is cross-sectional studies, also known as prevalence studies. These types of study, they do everything at the same time. We measure exposure and outcome simultaneously. So you can think of it as a snapshot of the disease picture within population. We determine disease proportion and compare them among those with and without the exposure or at varying level of exposure, and then examine the association. They are more appropriate for evaluating association between chronic diseases and chronic exposures, and sometimes useful for common acute diseases of short duration. So here's the schematic. We start with the defined population, gather data on exposure and outcome at the same time, and then compare proportion of those who were exposed and have the disease to those who were exposed and do not have the disease, and those unexposed with and without the disease. So kind of we do it all at the same time. Okay, and the last on the list is the ecological study. And the unit of observation in an ecological study is the population or community. So disease rates and exposures are measured in each of a series of populations. And then information may be abstracted from published statistics. So it does not require extensive or time-consuming data collection. But basically, we use the population data to assign those values to the individual. So for example, in the study of air pollution and cardiovascular disease, we could compare the published air pollution rates and hospitalization due to cardiovascular disease. We do not measure each individual's air pollution in their breathing zone, so we did not assign everybody the monitor to measure air pollution. And same thing, we do not recruit individual people for cardiovascular disease. So this is on a larger scale, comparing different populations or different communities. And here is the summary of the different studies. So we have analytic and descriptive studies, and analytic are experimental, and then observational studies are cohort, cross-sectional, case control, and ecological. Let's see if there are any questions on the study design. Somebody said they're not sure why disease with long latency period isn't suitable for a cohort study. It may be suitable, you just need to ensure that the time for conducting cohort studies is sufficient for the disease to develop. So same example, I'll use the same example. If we were doing a study of cancer, but a cohort study only lasted for a year. A year may not be enough for cancer to develop. It may take 10 years, 20 years, 30 years. So we just need to ensure that we allow sufficient time for the disease to develop. And that's more of a case for both prospective and retrospective cohort studies. So you can imagine with cancer again, if we were using existing records, but we went back only 5 years from the exposure to disease. 5 years, again, would not be enough for cancer to develop. So anytime we deal with long latency of the disease, we need to ensure that that time interval is accounted for in our studies, and there is enough time for the disease to develop. Somebody asked whether case controls in cohort can be used for rare diseases. So case control, yes, we can assemble a number of people with this rare disease, find appropriate control group, and then look for exposures. But with a cohort study, imagine if you're dealing with a rare disease, you would need a very large number of exposed and unexposed people, follow them forward in time. And because the disease is rare, at the end, only maybe 5 of those people develop the disease. So it would not be efficient. That's what we mean by efficient. With 5 people developing the disease, your comparisons that you can make are very limited. You will not be able to come up with meaningful estimates of the disease. So case control study is appropriate for rare diseases. Cohort study is not appropriate for rare diseases. What is the difference between case control and cross-sectional study? Case control, we start with disease information. So we recruit people with the disease, recruit people without the disease, and look for exposure information. With cross-sectional, we do everything at the same time. It's a snapshot of the population. So you can think of it as a survey of the population. And we asked about diet, but we also asked about physician-diagnosed diseases. So all the information is obtained at the same time. There is no time component. There's no difference in time component. Okay. Very good questions. Let's keep going here. And talk about calculations next. So before we talk about those beloved calculations in epidemiology, I want to clarify the probabilities and odds. So probabilities is that a chance that event will occur. So probability ranges from 0 to 1. And we denote it as P, probability that event has occurred, and 1 minus P is the probability that event did not occur. So of course, on the sum of they have to add up to 1. The probability that somebody will die plus probability that somebody will not die is 1. Either one of those scenarios must happen. Okay. Here's the same data on coronary heart disease and smoking. What is the probability of coronary heart disease? So it's number of people with coronary heart disease divided by total population, or 0.02. And that brings us to relative risk. It's the most commonly used measure. It's calculated by dividing incidence among exposed by incidence among unexposed. So incidence among exposed divided by incidence among unexposed. It approximates how much it is more likely for the outcome to be present among a certain group of participants than among another group. And here we have exposed and unexposed. So relative risk equal 1 means that risk is the same in the two groups. There was really no association between exposure and outcome. So incidence among exposed is the same as incidence among unexposed. Relative risk less than 1 implies that the risk is higher in the unexposed group. So less than 1, you can see that for that to happen, the denominator has to be greater than the numerator. So the risk is higher in the unexposed. So that is true for protective exposures. For example, exercise in coronary heart disease, or diet high with diet full of fruits and vegetables on certain cancers. Relative risk greater than 1 implies that the risk is higher in the exposed group. So this would be smoking and lung cancer. The incidence among exposed is higher than the incidence among unexposed. So these are harmful exposures. Here's an example of this calculation. These data are hypothetical of sleeping position and crib death. So how the sleeping position of a child and whether or not they had crib death. So there were 15 deaths total, and the population was 2,607. So 1 year cumulative incidence in the prone, among those with prone sleeping position, was 9, the number of deaths, divided by 846, so total number of exposed, or 10.64 per 1,000. The cumulative incidence among unexposed was 6, divided by 1761. The total unexposed was 3.41 per 1,000. The risk ratio is cumulative incidence in exposed divided by cumulative incidence in the unexposed. 10.64 divided by 3.41, or 3.1. We interpret it as the risk of crib death associated with the exposure, or in this case, prone sleeping position. So we see that it's a 3-fold increase in the risk of crib death with this sleeping position. Odds ratios are useful because relative risk requires an estimate of the incidence of the disease. So occurrence of new cases of the disease. But for case control studies, we do not know the incidence of the disease because we determine the number of cases and controls when the study is being designed. We start with our existing disease cases and non-disease controls, and we look for occurrence of exposure. We do not have those new cases of the disease to calculate incidence rate. So for case control studies, we use odds ratio as a substitute because we don't have incidence required for relative risk. Odds is another way of representing probability. And odds is the ratio of probability the event of interest occurs to the probability that the event of interest does not occur. And they're estimated by the number of times that the event occurs to the number of times that the event does not occur. So here is the same, basically the same thing in a mathematical form. So odds is probability divided by 1 minus probability, which is the same way, same thing as saying the probability that event does not occur. So odds ratio is the ratio of the two odds. And it could be for 2 different exposures, or exposed, unexposed. So here's an example of odds ratio. We have a case control study of 200 coronary heart disease cases and 400 controls to examine the association of smoking with coronary heart disease. What is the probability of smoking among coronary heart disease cases? So the probability of smoking is the number of smokers, or 112, divided by total cases, because the question was among CHD cases. So it's 112 over 200, or 0.56. What is the odds of smoking among CHD cases? Well, it's the probability that event occurred, 0.56, divided by 1 minus probability that event occurred, or 0.44, which is 1 minus 0.56, or 1.27. What is the probability of smoking among controls? It's the same thing. So it's number of smokers divided by total controls, 176 divided by 400. What is the odds of smoking among controls? Well, it's probability divided by 1 minus probability, 0.44, divided by 0.56, or 0.79. And the odds ratio is the ratio of odds. So it's the odds of smoking among cases, which we calculated on the previous slide as 1.27, divided by odds of smoking among controls, or 0.79, and it is 1.62. So we interpret this number as odds. The odds of smoking is 1.62 times higher among cases than compared to controls. So basically it shows us that smoking is harmful when it comes to coronary heart disease. And we got around to not needing incidence. We just use odds to calculate this measure of association. Here's another way to see the same calculation. So this is the 2x2 table, shows the disease and non-disease group, and then exposed and unexposed. The relative risk, remember, it requires incidence. So it's a number of people with the disease, A, over A plus B. So it's incidence among exposed, and A plus B is the total exposed. In the denominator of relative risk, it's incidence in unexposed, or C over C plus D. So it's number of people with the disease divided by total unexposed. So that's our relative risk. The odds ratio is the ratio of odds. So it's odds of this exposure among those with the disease, or A over C, divided by odds of exposure among those without the disease, B over D. And it is oftentimes shortened to be AD over BC. But when you calculate, make sure the table is set up correctly. A lot of times students make a mistake of doing the right calculation, so they calculate AD over BC, but the table would be reversed. So the column headings would be exposed and unexposed instead of disease and no disease, and the calculations end up being wrong. So if you think of odds ratio as the ratio of odds, and it's odds of exposure among the disease divided by odds of exposure among no disease, then you'll never make a mistake. So odds ratio is odds of exposure in cases divided by odds of exposure in controls. If it's 1, it means the numerator and denominator are the same. The odds of exposure were the same in cases and controls. So exposure is not associated with the disease. Odds ratio greater than 1 means the numerator is higher. So exposure is positively associated with the disease. And that would be harmful exposure, so smoking and lung cancer, or poor diet and obesity. Odds ratio less than 1 means exposure is negatively associated with the disease. So you can think of protective exposures, exercise, and lower risk of coronary heart disease. So both odds ratios and relative risk compare the likelihood of an event between two groups. Odds ratio compares the relative odds of an event in each group, whereas relative risk compares the probability of an event in each group. It is more natural interpretation. It's easier for us to think of the risk of the disease instead of odds, but relative risk cannot always be computed. If we don't have incidence data, we cannot calculate relative risk. So interpretations sometimes are ambiguous when you read literature. So So here is another example. A case control study is a study comparing ovarian cancer cases with community controls found an odds ratio of 2 in relation to exposure to radiation, which is the correct interpretation of the measure of association. And the correct answer is C. Ovarian cancer cases had two times the odds of exposure to radiation when compared to control. So if you ever get confused, think of what the odds ratio calculated. What did you calculate it? Well, odds ratio is the ratio of odds. It's the ratio of odds of exposure among cases divided by odds of exposure among controls. And in this case, it was 2. So in general, odds ratios summarize associations from case control studies and cross-sectional studies, and relative risk can be used to summarize associations in cohort studies. Odds ratios can be used to estimate the relative risk when in a case control studies when cases are representative of all people with disease in the population. The controls are representative of all people without the disease in population, and the disease is rare. So for rare diseases, and when cases and controls are representative of their respective populations, then we can use odds ratio to estimate relative risk. And here how it works mathematically. So when the disease is rare, and here's a formula for relative risk, for rare diseases, the number of people with the disease, which is A and C, is pretty small. So A divided by A plus B, when A is very small compared to B, that can be approximated to A divided by B. And same thing for the denominator. When the disease is rare, the number of unexposed people with the disease will also be very small. So C is much smaller than D, and we can approximate C divided by C plus D as just C over D. So that ends up being, if we cross multiply, AD over BC, which is the same thing as odds ratio. So you can see when the disease is rare, the A and C are very small compared to B and D, and they can be approximated by just B over D. So that ends up being AD over BC, which is the odds ratio. Now for a matched case control study, and we'll talk about matching a little later, sometimes we matched based on certain characteristics that we believe to be meaningful. So you'll hear about a case control study where participants were matched on gender or age group. We describe the results for each pair. Once we match participants in a case control study, they're no longer independent. They become a pair. So we can have concordant pairs or discordant pairs. With concordant pairs, both cases and controls are either exposed or unexposed. So they act together. Either two people were exposed or two people were unexposed. With discordant pairs, either case is exposed and control is unexposed, or case is unexposed and control is exposed. So here is the table. With matched case control studies, we look for discordant pairs. So concordant pairs in this case are A and D, but we only care for the odds ratio for the discordant pairs, which is B and C. So B is where case is exposed and control is unexposed. And C is case is unexposed and control is exposed. So for matched case control study, odds ratio is based on discordant pairs, and it's B over C. So we start with unexposed case, unexposed control divided by C, which is unexposed case, exposed control. In each cell in this case represents a pair. So here's another question. Cohort study is to risk ratio as ecologic fallacy is to cross-sectional study, case control study is to odds ratio, genetics is to the environment, rate ratio is to ecologic study. And the correct answer is B, case control study is to odds ratio. Basically, both are asking what is the right measure of association for that study design. And it was risk ratio for cohort study, and we know that for case control study, we calculate odds ratio. Let's see if there are any questions. Okay. Heather, I think this would be a good time for a short break. So let's take a 10-minute break.
Okay, that sounds fine. How long would you like to take?
Say that again?
Sounds good.
Okay, thank
10 minutes
you.
sounds great.
Okay. Somebody asked what is the difference for odds ratio between matched and unmatched controls. So let me go back to that slide. So the unmatched is the usual care odds ratio, just what we calculated before. Let me go back and do that. So it's odds of exposure among cases, A over C, divided by odds of exposure among controls, B over D. For matched studies, it is B over C. So we just, for matched studies, we're dealing with pairs. It is, B is when cases exposed, control is unexposed, divided by C, which is case unexposed, control is exposed. Okay. So let's talk about measures of effect and association next. And Heather, I think your phone is unmuted, so we can hear typing. Thank you.
Oh.
So relative risk and odds ratio measure the strengths of the association, but they don't, we want also to know how much of the disease can be attributed to exposure, how much of the coronary heart disease risk experienced by smokers can be attributed to smoking. And neither odds ratio and relative risk address this. They measure the strengths of association. We also need the measures of occurrence in two populations. So measure of associations, for example, can tell us cancer incidence rates in males and females in Canada, or incidence rate of dental caries in children within a community before and after fluoridation. Those are the measures of association. The absolute measures are the rate difference. So they can be causal rate difference, incidence rate difference, incidence density difference, or attributable rate. So we'll start with those. The risk difference is often referred to as attributable risk. It is referred to the amount of risk attributable to the exposure of interest. How much risk can be attributed to exposure? So for example, in the birth cohort analysis, where exposure was prenatal care in the first 5 months, the risk difference would be risk in exposed minus risk in unexposed. It's excess risk in preterm birth attributable to prenatal care. So you can think of risk in this dynamic. On the y-axis we have, in this figure, on the y-axis we have incidence proportion. The first bar shows unexposed, the second bar shows exposed. So the risk difference or excess risk can be thought of the background risk in the population. What is the difference between exposed and unexposed risk? This excess risk is what we're trying to determine. How much extra disease can be attributed to exposure. So if exposure is thought to cause disease among person exposed to this exposure, what amount of incidence of the disease is that exposure responsible for? The other amount of the disease in the unexposed can be thought of as the background risk. So think of it as, let's say, smoking and lung cancer. Some people smoke, some people do not smoke. But even those who do not smoke, some of them get lung cancer. So a proportion of the disease is background risk in the population. It's the incidence rate in unexposed. The excess risk in the population due to exposure is what we're interested in. Because if we prevented exposure, we would prevent that part of the disease from occurring. So if we eliminated exposure, this top part of the figure would be eliminated. This excess risk would be eliminated. So the risk difference, let's go back to the sleeping position and crib death example. The cumulative incidence among the exposed was 9/846. The cumulative incidence in unexposed is 6 divided by 1761, 10.46 and 3.41. So the risk difference is the difference between these measures, 10.64 minus 3.41, or 7.23 per 1,000. So this is the added risk due to exposure. So this amount of disease can be attributed to exposure. And if we eliminated exposure to this prone sleeping position, we could eliminate 7.23 per 1,000 cases. So this is the risk difference. The attributable risk percent is the risk difference divided by risk in exposed. So it's the incidence in exposed minus incidence in unexposed divided by incidence in exposed times 100. So it's a percent or proportion. It answers the question, what proportion of the occurrence of disease in exposed persons is due to that exposure? And here's the same example. So we already calculated cumulative incidence in exposed and cumulative incidence in unexposed. The attributable risk percent is the cumulative incidence in exposed minus cumulative incidence in unexposed divided by cumulative incidence in exposed times 100. So it's 10.64 minus 3.41 divided by 10.64 times 100, or 68.0%. So this is attributable risk percent. The population attributable risk is similar to attributable risk, except now we're dealing with the population. It answers the question, what is the excess risk in the population that's caused by exposure? So it's the incidence proportion, the total incidence proportion minus the incidence proportion in the unexposed. And the population attributable risk percent answers the question, what proportion of occurrence of disease in the population is due to exposure? So it's the total minus unexposed divided by total times 100. So population attributable risk is useful because it can tell us whether resources should be allocated to controlling exposure, or instead whether we should focus on something else. So the incidence if that exposure is harmful and causes a lot of the disease, the population attributable risk should be similar to the exposed population. Whereas with the exposure is relatively rare, the population incidence should be similar to the unexposed. So if we look at the same example, the population attributable risk percent is the cumulative incidence total, which is 15 divided by 2,607 or 5.75 per 1,000 minus cumulative incidence in unexposed or 3.41 per 1,000, which we already calculated before, or 2.35 per 1,000. The population attributable risk percent is the cumulative incidence total again, or 15 divided by 2,607 or 5.75 per 1,000 minus the cumulative incidence in unexposed or 3.41 per 1,000 divided by cumulative incidence total 5.75 per 1,000. So it's 5.75 minus 3.41 divided by 5.75 times 100. So it's population attributable risk percent of 40.8. Another way to calculate population attributable risk percent is to look at the prevalence. So it can be also rearranged, the formula can be rearranged as prevalence of exposure times relative risk minus 1 divided by prevalence of exposure times relative risk minus 1 plus 1 times 100. So suppose you were given only the prevalence and relative risk information, you could still calculate population attributable risk percent. So population attributable risk percent is affected by the prevalence of exposure in the population and the relative risk. And here is the summary of all formulas. So risk difference is answers the questions among persons exposed to our exposure, what amount of disease is that exposure responsible for? So how much disease could be eliminated if we eliminated the exposure? How much of the disease can be attributed to that exposure? The attributable risk percent tells us what proportion of the occurrence of disease was due to the exposure. So it tells us what proportion of the disease. The attributable risk to the population or population attributable risk tells us what is the impact for the population. Should the resources be allocated to controlling that exposure or some other exposure that has a greater impact on the population? And the attributable risk to the population attributable risk percent is what proportion of the disease in the population it can be attributed to exposure. So if a lot of the disease can be attributed to exposure and exposure can be eliminated, what impact would it have on the population in terms of disease occurrence? So absolute measures such as attributable risk address questions about public health impact on the exposure. They measure the excess risk in the exposed or population that can be attributed to exposure. The relative measures address questions about etiology and relationships among exposure and outcome. So it's a relative difference in risk between exposed and unexposed population. They show us the strengths of the association between exposure and disease as opposed to excess risk in the exposed population that could be attributed to exposure. So I know this is very confusing. Any questions? Okay. Let's keep going and talk about causal inference next. So causal inference is a big part of epidemiology because that's the reason we do our study. We're trying to determine whether exposure causes the disease so that we can prevent disease by controlling the exposure of interest. So one of the main definitions for a cause is that which produces an effect, result, or consequence, or the one such a person, event, or condition that is responsible for action and result. So definition of a cause implies the reason and occasion. Some of the key components, key characteristics of a cause is the essential attributes. So we have association, time, order, and direction. Association means there is an association between exposure and disease. So this would be measured by odds ratio, relative risk, for example. They would be either greater than 1 or less than 1. So there's no, there is some relationship between exposure and disease. Time order means there is a time component. So exposure must happen before the disease. For something to be a causal factor, it must happen before the outcome. For that exposure to be causing the disease, it must happen before the disease. And direction is referring to this relationship as well. So it's not a two-way association. The exposure causes the disease, which in turn causes the exposure. There is a one-way relationship. So causes can include host and environmental factors, things in the environment, the personal characteristics, and it can have active agents or static conditions. So active agents is something that's active in the organism. Static conditions are things like age, gender, race. We can use them to describe the difference in relationship, but they're not really changing anything. And causes may be either positive, where presence induces the disease, so this would be harmful things, or negative, where absence induces the disease, so protective exposures. For example, vitamins or good exercise practices, these are protective, so there are negative causes. Here's a diagram of the famous epidemiologic triad. So we have this relationship between agent, host, and environment. So agent is something that causes the disease. Host is the person where the disease is occurring, and the environment is everything else. So it could be the actual environment, such as air pollution or water quality, or it can be other more hidden things like socioeconomic status or education level. We know those are associated with disease, but they're external to the host. Here's an example for malaria. We have a host, a person, agent, the actual virus, vector, the mosquito that transmits the virus, and the environment, the presence of water or contaminated water. So in epidemiology, we often don't know all the causes, but we use risk factors instead. It's a cautious way of making causal inference. They're not direct causes of the disease, but they can serve to identify proximate causes. So risk factors are used in place of causes to identify the exposure-disease relationship, the causal mechanism. Some background. So in the 50s and 60s, epidemiologists developed a set of postulates for causal inference regarding non-infectious diseases of unknown etiology. And it came as a response to discovery of association between smoking and lung cancer. So there were a lot of debates, and they yielded 5 criteria in the 1964 report to the Advisory Committee of the U.S. Surgeon General on Smoking and Health. So in 1965, Sir Austin Hill came up with the best known criteria, all guidelines for causal inference. And then 76, the Rothman presented his view on the sufficient component theory of causation. So let's talk about the Hill criteria for causation. These are 9 criteria, and even though there are criteria, they're used as guidance. So they're not designed to be these concrete rules to determine if something is, if there is a causal association between our exposure and our disease. So first is the strength of association, meaning the stronger the relationship, the more evidence it provides to causation. So think if something has a relative risk of 1.1 versus a relative risk of 10. Of course, we can give more weight to the stronger association. Consistency means the results are similar in different settings. So if we did the same study in different populations, would we find the same results? Specificity of association came from a microbiology world. So this one microorganism caused this one disease. So of course it does not apply to all exposure disease relationships. The temporal relationship is the one thing everybody agrees on, and it's when exposure must come before the disease. So there is this temporal relationship between exposure and disease. First you have exposure, then you get disease. Why? Well, because if exposure happened after the disease occurred, it could not have caused the disease. So temporal relationship is one thing everybody agrees on. Biological gradient is when we see this dose-response relationship between exposure and disease. So yes, theoretically, the more well, let's say smoking and lung cancer, the more a person smokes, the higher their risk of lung cancer, but biological gradient may not apply if it's not a direct linear relationship. So some associations may be more complex. Let's say a U-shaped curve would be masked, would not show a biological gradient when in fact there is a causal relationship. Biologic plausibility means, does it make sense given what we know about the biology of the disease? Coherence, are the results consistent across the different settings or different populations? Experiment means when we vary that exposure-disease relationship, do we get, when we vary the amount of exposures, do we get a resulting change in disease occurrence? So if we did an experiment and we doubled the amount of certain exposure, do we get an increase in the outcome as well? So this is a basis for experimental studies, and of course they would demonstrate causality. An analogy means, is it similar to what we know already about other similar types of diseases in similar populations? So as you can see, all of these can be refuted with the exception of temporal relationship. For something to be a cause, it must happen before the outcome. The Rossmann sufficient component cause model states that all the causes, there are different types of causes, and sufficient cause is a complete causal mechanism that inevitably produces the disease. It's all the pieces of the disease puzzle came together, and now the disease can occur. So sufficient cause is not a single factor, but rather a minimal set of factors that inevitably produce the disease. So for example, sufficient cause for AIDS may include exposure, HIV infection, susceptibility, lack of preventive exposures for the disease to develop. And each participating factor in a sufficient cause is termed a component cause. So in the previous example, the component causes could have been exposure, HIV infection, susceptibility, lack of preventive exposures. So there are several component causes within a sufficient cause. So sufficient cause precedes the disease, and if the cause is present, the disease always occurs. Think of sufficient cause, okay, now it's sufficient for the disease to develop. All the relevant components are in place, it is sufficient, the disease can now occur. The necessary cause, it precedes the disease, and if it's absent, the disease cannot occur. So that cause is necessary for the disease to occur. It's the one thing that has to happen before the disease can develop. And there are 4 different types, so a cause can be necessary and sufficient. Without that factor, the disease never develops, and in the presence of that factor, the disease always develops. It's necessary and sufficient. There is necessary but not sufficient, and that means without that factor, the disease never develops. But there are other mechanisms to get the disease to the disease as well. It's not sufficient. You need other factors for that disease to occur. The sufficient but not necessary means the factor can produce the disease, but so can other factors. So there are several routes to get to the disease. And neither necessary nor sufficient is where most of the diseases are. The factor itself cannot cause the disease, but plays a role. And multiple factors interact to cause the disease. So there are several different pathways. There are several different routes to get to the disease, and neither of those components is necessary. So we can find other ways to get to the disease. Some attributes of this model is that blocking an action of a single component stops the completion of the sufficient cause and thus prevent disease from occurring by that pathway. So it's useful from a preventive standpoint. If you knew something was, if you knew what the component cause was and you prevented that component from happening, that would prevent completion of that puzzle, and the sufficient cause would not be complete, so the disease would not develop by that pathway. So completion of sufficient cause is synonymous with the biologic onset of the disease. Once that puzzle is complete, the disease can develop. Not all components are equal. Some may be distant and others more proximate. So think of the gene mutation in the tumor development. That would be a more distant cause. A more proximate cause would be maybe exposure to flu virus. So some take longer time to act, to come into play for the disease to develop. So associations between exposure and outcomes are identified in observational studies, but they may or may not be causal. Yes, it is our goal to show causal association, but we need to take into account other aspects of the study. So we need to pay attention to valid assessment of exposure and outcome to think about causality. You know, only in a perfect world would we do a perfect study, and that's not always the case. So we need to be thinking about reliability and validity. And we'll talk about those next. So let's see if there are any questions before we transition to talk about validity. do sufficient causes always lead to the disease? So a sufficient cause, let's go back. Yes, sufficient causes always lead to the disease. So according to this model, it's a set of component causes that inevitably result in disease progression. So if you go back to HIV example, it could be either using infected needles with absence of antiretroviral drugs. So that would be one sufficient cause. Another sufficient cause would be perhaps through birth. So an infected mother giving birth to a child may transmit the infection, and that would be another sufficient cause. A sufficient cause is really a pathway to the disease occurrence. There could be several pathways that could happen for the disease to occur. Okay. Let's keep going and talk about validity next. So validity implies that a measure actually measures what's expected to measure. It shows us accuracy. So a valid measurement would be appropriate and accurate. A valid measurement shows the real phenomenon being investigated. It implies that the findings are the truth. So it's the degree to which a measurement of study or study reaches the correct conclusions. There are two types of validity, internal validity and external validity. Let's start with external first. External validity is generalizability. So it is the extent to which the study results are applicable to the general populations. Do the study results apply to other patients? How can we use the conclusions obtained in this study for another population? If we can be more confident in generalizability or external validity if a representative sample is drawn from the population. So if we recruited our participants in such a way that they were representative of the population, we can be more confident that the results we obtained in our study can be applicable to that source population. So we can say that results were generalizable to the main population. Usually we have some sort of sampling frame, and if we randomly selected participants and we know that they were representative of the population, we can be sure, we can be more confident that the results can be generalizable, or we had high external validity. So the objective is to make inferences back to the source population, and the more representative the sample is, the better job we did with selecting participants, the more confident we can be that the results can be generalizable. Internal validity means the extent to which the results of the study accurately reflect the true situation of the study population, and it's influenced by chance, bias, and confounding. So let's start with chance. Chance is the random error. The random error is the term more commonly used. It's part of our experience that we cannot predict, and it's more easily conceptualized as sampling variability, so it can be influenced by sample size. So if you were flipping a coin, just by chance you could have 8 times out of 10 as heads. So this is a kind of random component of the study. It applies to measurements, it applies to assessment of outcome, so it can affect our internal validity. The more random error we have, the lower validity of the study we see. The influence of random error can be reduced by increasing sample size. So the higher the number of our participants, the less random error we would see in the study. So if you were doing a blood pressure measurements and you just did one measurement on 10 people, just by chance there could be some variation. Whereas if you had 1,000 people in your study and you did 4 measurements for each person, then we could be more confident in those results. So by increasing sample size, we can minimize the effect of random error. We can improve precision of instruments, so the better instruments we use, the less random error we will see in our study. And there is probabilities that some types of influence can be quantified. So the more random error you have, the wider confidence intervals are expected. So you can think of it as kind of noise in your data. The more noise you have, the less precise estimates you get, and the wider confidence intervals are. Bias, on the other hand, is a systematic error. It's not random or due to chance. It's a systematic error that leads to incorrect estimate of association between exposure and disease or outcome. So bias is a systematic error that results in incorrect estimate of the measure of association. Why are we concerned about it? Well, because we want to do a study and come up with conclusions. If we have bias in our study, we know that we reached incorrect conclusion. And that's, of course, is not good in an epidemiologic study. So bias is a systematic error that results in incorrect or invalid estimate of the measure of association. It can create an association when there is none. So we call it bias away from the null. It can also mask an association when there is one, and that would be bias towards the null. So there is actually an association between exposure and disease, but because we have bias, we were unable to detect that association. So we say association was masked. Bias is introduced by investigator or study participants, and this does not mean that the investigator was prejudiced or they did not have good epidemiology training. Just means that there was some systematic error that resulted in incorrect estimate that was obtained. Bias can occur in all study types, and it can happen in all aspects of the study, whether it's design or conduct of the study. And bias can be evaluated but not fixed in the analysis phase. So once we have bias, we can only evaluate its effect if we collected the appropriate data. So let's talk about selection and observation bias next. Just to clarify, bias towards the null means that the observed value is closer to 1 than the true value. So if we did our study, the null would be 1 for relative risk or odds ratio. And we have bias towards the null, meaning what we found, the true measure of association, is actually further away from the null. So for example, if the true measure of association was 3, odds ratio of 3, if we had bias towards the null, we would observe an odds ratio of 2, for example. So 2 is closer to the null of 1 than 3, so there was bias towards the null. And null means, or 1 means there is no association between exposure and disease. Bias away from the null means that the observed value is further from 1 than the true value. So it can be in positive or negative direction, but let's say the true measure of association was 3 again, but because we had bias away from the null, we see that the measure of association is 4, not 3. Or it can be in the negative direction, -2. So both are bad because what we really want is our observed measure of association to be as close to the true measure of association as possible. And here's just a summary slide, but I'll start with selection bias first. Selection bias is a systematic error that occurs in the process of identifying study population. It's an error that happens when we find people for our study. It occurs whenever the identification and selection of individual subjects for inclusion into study is not independent of outcome or exposure for case control study. It's error due to systematic difference between those selected for the study and those not selected for the study. So selection bias is a systematic error that occurs at the selection of participants into our study, and we end up with systematic difference between those who were selected and those who were not selected. So for example, if procedures used to select subjects led to different results than what would we find had the entire population participated in our study. It is more likely to occur in case control in retrospective cohort because exposure and outcomes have occurred at the time of study selection. Selection bias can also occur in a prospective cohort and experimental studies because of differential loss to follow-up. So suppose more people on the experimental drug or experimental treatment dropped out from our study. So we have this differential loss to follow-up, and we could still have selection bias. So again, it's a systematic difference between those selected for the study and those who are not. And we can determine the extent of selection bias by looking at the number of those who refuse to participate, the non-participants, the non-responders, or how many people were excluded. If we fail to enumerate the entire population, so our sample was not representative of the target population. Again, those lost to follow-up, if the loss to follow-up was related to exposure or outcome, and differential selection of exposed and unexposed group or cases and controls. Volunteers, of course, most study participants are volunteers, but we'll have to see if those who volunteered were somehow different than those who did not volunteer to establish the extent of selection bias. Healthy worker effect is also common, so workers tend to be healthier than the general population. So when we do studies in occupational settings, we have to be mindful that the sample we selected was representative of the population and somehow not associated with the part of information we were looking for. So those who were selected into the study were similar than those who were not. Selection bias occurs when selection of exposed and unexposed subjects is not independent of outcome. For example, a retrospective study of occupational exposure to asbestos and lung disease in a factory setting. Those who were exposed and unexposed are enrolled on the basis of prior employment records. Now, the records were old and many were lost, so the complete cohort of those working at the plants was not available at the time of the study. And if people who did not develop the disease and were exposed were more likely to have their records lost, then there will be an overestimate of the association between exposure and disease. So basically, we need to select participants into our study in such a way that is independent of the information we're looking for. So here we did a cohort study looking at occupational exposure to asbestos and lung disease, and if more records were lost among those without the disease, then it would not be comparable for exposed and unexposed. So selection bias could occur. So selection bias, remember, we need to select participants in such a way that it is independent of the outcome we're looking for, and that the sample is representative of the larger population. Some solutions to minimize selection bias are to increase participation. Of course, the more participants you have, the more likelihood that they're representative of the population. We usually get information on refusers, again, to see whether refusers were different or how similar they were to study participants. To avoid loss to follow-up, we develop follow-up mechanisms, use comparable population, and valid assessment of outcome in a prospective cohort study. So to blind, for example, to use blinding. Some additional sources of selection bias in a case control study is when it comes to decisions for incident or prevalent cases. The prevalent cases reflect the survival component, so the disease duration. And controls need to reflect the population that gave rise to cases. So controls must be representative of all people in the population that did not get the disease. The selection of cases and controls must be independent of exposure, because that's what we're looking for. We're looking for exposure distribution among cases and controls. So we have to select our cases and controls independently of that exposure. We'll compare whether cases and controls have higher or lower prevalence to those not selected into the study. So cases and controls should have the same exposure opportunities. For example, we wouldn't compare welders in general population and their exposure to particulate matter, because welders have much higher exposure. So although participants are selected based on the disease only in the case control study, on the cases selected because they have the disease, controls selected because they don't have the disease, and that selection is independent of the exposure status. The exposure information is what we're looking for. It's a second piece of that puzzle. So selection bias in case control studies occurs when cases and controls are more or less likely to be included in the study if they had been exposed. So inclusion must be independent of exposure. If that does not happen, what we see as association between exposure and disease would be different from the relationship between exposure and disease in eligible individuals who are not included. And the odds ratio from a study that suffers from selection bias will be incorrectly representative of the relationship between exposure and disease in the overall study population, which is what we're trying to estimate. In cross-sectional studies, selection bias can occur when sampling frame does not represent the underlying population of interest. So if we did a study based on driver license records, for example, those would exclude everybody without a driver's license or somebody who does not have a car. So we need to be mindful of what kind of implications that would have on our research question. How excluding people without driver's license would affect our study results. How is it making a difference? So again, in cross-sectional studies, selection bias can occur when estimates do not take into account the sampling structure, and if there are sufficient number of refusers, then the underlying sampling structure is compromised. So if our study sample is no longer randomly selected from the population, it would not be representative. So the estimates of associations would not be an accurate reflection of what's going on in the population. Once it happens, there is really nothing we can, little we can do about selection bias. We need to avoid it or minimize it to the best extent possible in the design and implementation phase. So we would use the same criteria for selecting cases and controls, obtain all relevant subject records, obtain high participation rate, and take into account diagnostic patterns of the disease. So any questions on the selection bias? Somebody asked if anecdotal reports have lower validity than experimental studies. So we'll talk about this in a little while, but basically whenever we ask people to report information, there could be some error in reporting. So that's known as recall bias, and we'll talk about that next. So selection bias, it's something that happens when we select participants into our study that results in them being no longer representative of the study population. And if we have a case control study, selection must be independent of exposure. In a cohort study, selection must be independent of outcome. So that was selection bias. Observation or information bias is an error that arises from systematic differences in the way information on exposure or disease is obtained from the study groups. So before we were selecting participants, now we're getting information from them. Any systematic error with how we get this information results in observation or information bias. So for example, we can have participants who are incorrectly classified as either exposed or unexposed or disease or non-disease. And it happens after the subjects have entered the study. So this is after the selection. And there are several types of observation bias. So recall bias is when people with the disease remember or report exposures differently than those without the disease. So the kind of common example is a mother who gave birth to a baby with birth defects will think back on her pregnancy and think back on the things she ate and the hair products she used to try to explain this outcome. Whereas a mother who gave birth to a healthy baby would not do that. So the recall of exposures is different based on the outcome. And this can result in over or underestimation of the measure of association. Some ways to overcome recall bias are to use controls who are themselves sick with another disease, thinking they went through the same mental exercise of trying to explain different diseases, and that would minimize recall bias. The standard questionnaires are always a good thing. We want to obtain information in as consistent manner as possible from all participants. And then we mask subjects to study hypotheses. So do not reveal what your real hypothesis is, so that whatever their prior knowledge, participants' prior knowledge cannot influence their response. Interviewer bias is systematic difference in soliciting, recording, or interpreting information. It can occur whenever exposure is thought when outcome is known, as in case control, or when outcome information is thought when exposure is known, as in the cohort study. So, for example, if interviewer was soliciting information differently from people with the disease than people without the disease. Whenever there is possibility of probing, so for example in-person interviews or telephone interviews, and the outcome has already occurred, information bias, interviewer bias is possible. So often to deal with it, we mask interviewers to study hypothesis and disease or exposure status of the subjects, so there is less likelihood of probing or leading the interviewee to get the response. So standardized questionnaires will help address that as well. biomarkers to compare whenever possible. So that's always a good thing whenever we can avoid asking people altogether. So instead of asking about nicotine consumption, we could do a blood test and then test for actual nicotine metabolites. That would be more accurate of the exposure than asking people to report their nicotine consumption. And surrogates tend to underreport exposure, so sometimes we rely on proxies, for example, a spouse or a child, to get the relevant information. And depending on the exposures, they may be under or overreported. So classification of exposure and outcome can lead to misclassification bias. And if exposure is known in cohort studies or outcome is known in case control studies, then bias is possible. So one way to overcome it is to blind the data collectors on the exposure and outcome status so they can obtain the second piece of information, outcome and exposure, independently of the existing information. So misclassification bias is a type of information bias. It's an error arising from inaccurate measurement or classification of the study subjects or variables. The subject's exposure disease status is incorrectly classified, and it happens at the assessment of exposure or outcome in both case or control studies. And there are two main types, the non-differential and differential misclassification. The non-differential misclassifications is when inaccuracies with respect to disease classification are independent of exposure, or when inaccuracies with respect to exposure classification are independent of disease status. So you can think of it as just a poor job with exposure assessment or outcome assessment independent of the other piece of information. So if we were looking at disease classification, then misclassification would be independent of exposure. So if we're looking at outcome classification, the misclassification would be independent of exposure. So the probability of exposure or of outcome misclassification is the same for cases and control in a study and comparison group. This type of misclassification tends to bias the results towards the null if we have two groups, because it makes the two groups more similar. So if we misclassified exposure with respect, if we have exposure misclassification that's independent of outcome among cases and controls, then means cases and controls are now more similar with respect to their exposure. So a bias towards the null is expected. One way to overcome is to use multiple measurements so we can have the most accurate sources of information. The differential misclassification is the probability of misclassification of disease is different for exposed and unexposed groups, or presence or absence of exposure in a case control study. So it's different for cases and controls. For example, let's say 20% of cases are misclassified as exposed when in fact they're unexposed, but only 10% of controls are misclassified in their exposure. So this misclassification is different depending on the outcome. It's different for cases and controls, and hence the name differential misclassification. The direction of bias is unknown in this case. It can be overestimation or underestimation of the true risk. It is also known as systematic misclassification because it's correlated with the presence or absence of the characteristic. So in the previous example, with exposure misclassification, it was 10% for controls and 20% for cases. That misclassification was different based on the case control status, based on the case control group. So it was differential. Let me take a couple of questions now. How can we tell if it's a differential or non-differential misclassification based on numbers? That would really depend on the type of question or the type of study you're doing. Oftentimes in real world we don't know how much misclassification has occurred, but we need to make sure that the measurements we're obtaining and the exposure information we obtain is done consistently for cases and controls, and that any error that happens is independent of the group status. So it's independent of whether it was a case or control. One way to tell would be if you had some other gold standard. If you could do a blood test and then know the true exposure, then you could tell whether the true extent of exposure misclassification. Okay, let's talk about confounding next. Confounding is an alternative explanation for the observed association between exposure and disease. It is oftentimes referred to as mixing of effect of the association between exposure and disease, and it's distorted because of this presence of a third variable, the confounder. So confounding distorts the true association between exposure and disease, and it can happen either towards the null, or negative confounding, or away from the null, positive confounding. Confounder is associated with exposure, and independently of that exposure is a risk factor for the disease. So the three criteria for the confounder: first, it's associated independently with exposure. Second, it is a risk factor for the disease. And third, it is not on the intermediate, on the causal path. It is not on the causal path between exposure and disease. So it's not in that causal chain. Here is a diagram. So we have E as our exposure, D is the disease, and confounder is this third variable. So confounder is associated with exposure. It is independent risk factor for the disease, and it's not on the causal pathway. It's not on this direct link between E and D. Some opportunities for confounding in the experimental design is when participation is different in the study and control groups, or there is no evidence of randomization, or there is evidence of residual confounding. In cohort and case control studies, when selection of the comparison group is different by subject characteristics, or when risk factors other than the exposure are distributed differently between exposed and unexposed group. And so there is evidence of residual confounding. So in the design phase, the goal is to eliminate or reduce variation in the level of confounding factor between the groups being compared. And a variable can only be confounder if it's different between the compared groups. So here are the ways we control for confounding in the design phase. First is randomization. With a sufficient sample size, randomization is likely to control for both known and unknown confounders, because we presume that the randomization equally allocates participants in the two groups. So both things that are known confounders and unknown confounders will be equally divided in the experimental and control groups. And those factors can no longer be confounders. Restriction, we restrict admission to our study of those within certain category. So if we're restricted by gender, we would enroll maybe only females into our study. So the gender can no longer be a confounder because we restricted our sample only to females. Matching is another way to deal with confounder, is when we match subjects based on the potential confounder. So among cases and controls, we could match on gender and therefore eliminate confounding by gender. In the analysis phase, here are the ways to deal with confounding. Standardization, just as we saw with pyramids, we can standardize by potential confounders and eliminate the effect. We could conduct stratified analysis. So stratified means just divide up the data according to the levels of confounder. So we could do a separate analysis for males, separate analysis for females, and then compare the results. Matched analysis has to be done when we used matched design. Restriction, again, we could restrict our results to only one group. And multivariate analysis, we can adjust for several confounders simultaneously. So that's most commonly done. For example, we could simultaneously eliminate the effect of confounding by age, gender, and race. The effect modification, on the other hand, is an interaction. So the strengths of association between exposure and disease is different according to levels of another variable. It is modification of a relationship between exposure and the disease by a third variable. So if the association changes according to levels of the third variable, then effect modification is present. And this is different from a confounder that's associated with both exposure and disease, and it's not on the causal pathway. With effect modification, it just means that the exposure-disease relationship is different according to different levels of that variable. Okay, let's talk about measurement error next. Measurement error happens when we have to measure exposure and outcome or other key variables, and none of the measures are perfect, unfortunately. So the error can occur every time we're measuring something, and we need to decide which measures to use and how to interpret our results in light of specific measures. Reliability means how closely do duplicate measurements of the same characteristic agree with each other. Test-retest reliability is an agreement for two different tests. They can be either administered at two different points in time or by two different people. Intra-observer reliability is agreement of a given data interpreter with him or herself. So if I looked at the data today and I looked at the data tomorrow, how similar would be my assessment? Inter-observer means agreement among different interpreters. And reliability is usually higher with more standardized or automated measurement procedures, and it's lower with more complex judgment or something that requires human observation. Validity is the degree to which instrument measures what it actually wanted to measure. So in many epidemiologic studies, the characteristic is dichotomous. So we have disease, non-disease, exposed, non-exposed. So validity can be regarded as having two components, the sensitivity and specificity. The sensitivity is probability of testing positive if the disease is truly present. So if we have the true disease status as our column, the plus indicates disease, minus indicates no disease, and the results of screening tests is positive or negative, sensitivity would be A divided by A plus C. So probability of testing positive if the disease is truly present. Specificity is a probability of screening negative if the disease is truly absent. So it's D divided by B plus D. We oftentimes hear the true positive, false positives as well. So if the disease is present and the participant was tested positive, we call them true positive. If the disease is absent and the test was negative, they're true negative. If there is if the test is incorrect, so the disease was absent, but the person tested positive, they're false positive. And if the disease was present, but the person was tested negative, they're false negative. So sensitivity can be thought of as true positive divided by all those with the disease, or true positives plus false negatives. And specificity is true negative divided by all those without the disease, or true negatives plus false positives. One note is the higher the prevalence of the disease, so you can think of moving the line between the present and the absent of the disease to the right. So the higher the disease prevalence, the higher would be sensitivity of the disease. Lowering the criterion of positivity results in an increased sensitivity, but at the expense of decreased specificity. So all these are connected, and if we lower the criterion of positivity, basically make the test less stringent for us to make determination of whether or not that was a disease, that would result in increased sensitivity, but in turn result in decreased specificity. Making the criterion of positivity more stringent is on the opposite. It would increase specificity, but at the expense of decreased sensitivity. And the goal is to have high sensitivity and high specificity, but it is always not possible, so we have to make a judgment call. And the judgment call on the cutoff points has to take ethical considerations into account. What is the cost of leaving the disease undetected? Or what is the cost of labeling somebody as having the disease when in fact they do not? So we need to consider the implications of false negatives and false positives on the population. Sensitivity should be increased when penalty associated with missing a case is high. So when the disease can spread quickly, and when subsequent diagnostic evaluations are associated with minimal risk or cost, we'd rather err on the side of diagnosing somebody who has the disease when in fact they do not, because the disease can spread quickly. So we'd want to maximize sensitivity. Specificity should be maximized when the cost and the risk associated with additional diagnostic techniques are substantial. So we want to minimize false positive. So for example, when positive screening requires that a biopsy be performed. So it's very invasive, and specificity should be maximized in this case to minimize false positives. Here is an example of a question. A screening test is used in the same way in two similar populations, but the proportion of false positive results among those who test positive in population B is higher than among those who test positive in population A. What is the most likely explanation for this finding? And the correct answer is C, the prevalence of disease is higher in population A. Other measures of performance, of test performance, is the positive predictive value and the negative predictive value. The positive predictive value means the individuals with a positive screening test will also test positive on the diagnostic test. Or out of those who tested positive, how many would actually have the disease? And the negative predictive value, individuals with negative screening tests are actually disease-free or will also test negative on the diagnostic test. So if we went back to the same table, positive predictive value would be A, or true positives divided by all those who tested positives, A plus B. The negative predictive value is D, all those who are disease-free and tested negative, divided by all those who screened, who tested negative, C plus D. factors that influence these performance measures. The more specific the test, the higher is the positive predictive value. The higher the prevalence of the disease, the higher is the positive predictive value. And the more sensitive is the test, the higher is the negative predictive value. We always, or sometimes we also talk about the sampling error, so type 1 and type 2 error. Type 1 error means the chance of rejecting null hypothesis when it is true. So the table shows the reality and the decision. And sometimes we make the correct decision. So for example, the null hypothesis is true and treatments are not different. And we conclude that the treatments are not different. So we're in the top left-hand corner. So we came up with the correct decision. The other option would be treatments are in fact different, so the null hypothesis is false. And we concluded that treatments are in fact different, so we reject the null hypothesis. So we also reached the correct decision. Sometimes we reached incorrect decisions. So type 1 error is when treatments are in fact not different, so the null hypothesis is true, but we reject it. So it's the probability of rejecting null hypothesis when in fact it's true. The type 2 error is the treatments are different, the null hypothesis is false, but we fail to reject the null hypothesis. And power is 1 minus the probability of type 2 error. So I'll talk about outbreaks briefly next. I realize I'm close to the time limit. The endemic is the habitual presence of disease within a given geographic area. Epidemic is where occurrence of in a community or group of illness of similar nature in excess of what normally would be expected. So every year we expect a certain number of people to get the flu. Anytime we have a higher number of disease in the population that's more than what would be expected by chance, that's epidemic. The amount of disease depends on the number susceptible or at risk and the number not susceptible by way of immunization or genetics. And pandemic is a worldwide epidemic. There are several different outbreak types. The common source is when a group of persons exposed to a common agent, the point exposed over a brief period of time, so there is a brief period of time of exposure, intermittent exposure over long periods of times, propagated, spreads gradually from person to person, and some epidemics are mixed, so we can have a common source and from a person to person. How do we find outbreaks? Well, we'll rely on surveillance system to track disease or injury rates over time. They can only be used for those diseases that are reported. We only have surveillance for a certain number of diseases, and those are the rates we can look at. Those are things we can track. There is time delay between when diseases are detected by physicians and then reported into the surveillance system. Laboratory reports can be helpful. Healthcare institutions or hospitals would detect something that, or a disease that may be in excess of what would be expected. The information is collected by public health offices, and oftentimes it's the observant healthcare personnel that really raise the first flag. So with epidemic investigation, we establish the presence of epidemic, come up with a case definition. The case definition can change as we get more information on the disease. We need to communicate and come up with the control strategies, analyze the data to see the extent of the outbreak, form a hypothesis on disease progression and the spread, would then test that hypothesis and complete the investigation. So there could be several times we'll go through these steps in a disease process. So I know I'm out of time, but I can take a couple of questions. The question was about sensitivity and specificity, so let me go back to the table. The proportion of false positive results among those who test positive in population B is higher than those who test positive in population A. So if there were more false positives in population B, it means that the prevalence of the disease was lower. The more false, the higher the prevalence of the disease, there would be more true positives and fewer false positives. So more false positives in the disease in population B means the prevalence of the disease was lower in population B. And that was the question. So the proportion of false positive results among those who tested positive in population B was higher than among those. So we can conclude that the prevalence of the disease is higher in population A. Just the opposite, so you can think of it as the prevalence of the disease was lower in population B. I think we are out of time. I want to wish you best of luck in the exam. I'm sure you will do very well and you will get all the epidemiology questions correctly. So good luck.
Great. Thank you everyone for attending. As I said at the beginning, it is our goal to have this posted within 3 to 5 business days following the webinar today. You'll be able to find them at the same link that you registered on. You can find them at NBPHE. The link will be under Study Resources section as well as CPH webinars. Thank you very much for joining.
The organizer has ended the session.